Hello, my name is Leonard Conway. I'm a paramedic with Yale New Haven Health Center for EMS. This is going to be interosseous training, which is brought to you by Center for EMS and the code committees for each hospital in the system. Today we're going to go over interosseous placement, some contraindications, some indications, how to measure, how to place, and how to remove. So the first thing we're going to do is we're going to go over indications. Interosseous was started for emergency use, and it's still used for emergency use pre-hospitally and in the hospital. Now it's going to be brought to the OR for emergency use. Interosseous use is going to be used mostly in an emergency situation when we cannot gain access through an IV or a central line. Some things that we could do through an IO port is we could give any fluids that we could give through an IV. We could give any medications that we give through an IV. You could also give blood products, and you could take blood samples away. You could also give CT contrast through an IO. The only thing you cannot do through an IO is you cannot send somebody for an MRI with an IO placed because of the metal that's going to be in the patient. Contraindications for interosseous placement are going to be fracture in the targeted bone, previous orthopedic procedures at insertion site, possibly a prosthetic limb or a prosthetic joint, IO in the targeted bone in the last 48 hours, be it successful or unsuccessful, areas of infection, and excessive tissue, or you just can't find the landmarks. Let's go over the equipment for the interosseous. First, you have your pull guns or drivers. The smaller gun is going to be a 500 pull gun. The bigger gun is going to be a 750 pull gun, which means 750 actual drills. You're going to see on the back of the 500 drill gun, there's an indicator. If you test it and you see a green light, then you have over 10%. If you see it with a red light, then that means you have 10% pulls left on each gun. So this you would have 50 pulls maximum. This you would have 75 pulls maximum. There's 3 size needles for the interosseous. First, we're going to have our pink needle or your pediatric needle. This is going to be 3 to 39 kilos. The blue interosseous needle is typically your adult needle. This is going to be over 3 kilograms. The yellow interosseous needle is going to be your bariatric needle, or whenever we're doing a humeral head insertion on somebody over 40 kilos. Also in the interosseous kit, you're going to find a pink band. What this does is this lets other providers know that you started an interosseous on the patient. Here you could put your name, the patient's name, date and time which is started. You're also going to find this, which reminds us that these are not sternal IOs. You're also going to have a stabilizer, which you put on right after insertion of the IO needle. The first area we're going to measure is going to be the tibial tuberosity. The best way to think about this as big toe IO. If you're always in line with the big toe for either leg, you're going to be fine. We want to look for, obviously, the patella. Below the patella, at the top of the tibia, you have your 2 condyles, your lateral condyle and your medial condyle. What you want to do is find your medial condyle. You're going to go down about 1 inch below the medial condyle, or I've heard 2 fingers measured. After you go down about 1 inch, you're going to be on that flat area to the left of the tibial tuberosity, and that's where you want to place your IO. After we've properly measured our site for IO placement, we're going to begin the procedure. The first thing that we're going to do is we need to work with an aseptic technique. So you're going to clean the area with your choice of cleaning agent. Now we're going to place our needle onto our drill. We have to know that this is magnetic as well as the needle. So when you take the cap off, you have to hold onto the needle. You're going to see that on each needle, there's 2 or 3 black lines. When we insert the needle into the skin and the bone, we need to have black lines visible, at least one black line visible. What that means is if it is visible, it's long enough to reach the center of the bone into the marrow. If you put the needle through the skin and you don't have a black line, then that simply means that it's going to be too short and it's not going to make it into the middle of the bone. You want to, number one, have a good handle on the extremity that you're going to be placing the IO in. What you want to do is when you have your place measured out, you want to go towards it in a 90-degree angle. That's very important, a 90-degree angle with your needle and your gun. You want to push through the skin. You're going to feel a pop. You're going to stop pushing when the needle tip hits the bone. This is when you look at the needle and see if you see the black line. If you have a black line, then you're good enough. This is going to reach the middle of the bone marrow. If you don't have a black line, you need to change to a longer needle. After you confirm that the needle is going to be long enough, you simply pull the trigger and you let the drill do all the work. You're going to feel a pop and you're going to feel it drop down into the middle of the bone. You have to carefully hold on to the hub when you take the gun off. Now you're going to do your first placement, actually your second placement. Your first confirmation of placement is that you properly measured the right area where you're going to IO. The second confirmation of placement is that it's sturdy. If it's wiggling back and forth, I wouldn't feel comfortable with it. If it's very sturdy like this, that's another confirmation that the IO is in properly. Now we have to break the top from the bottom of the IO. You have to hold the bottom of the hub and you have to turn the top counterclockwise. You're going to take your stylet out and you're going to put your stylet into your sharps container. This stays in very well to ensure that nobody gets stuck. When you have time after, you're going to place this right into a sharps container. Now we have our access. To measure for humeral head insertion, it's important that you first place the hand of the intended arm over the umbilicus, so you bring the humeral head forward. You're going to place your hand in the axilla with the top of your fingers equal to the top of the shoulder. You're then going to place your other hand back here. You're going to bring your 2 thumbs together. Where your thumbs are together right now, they say that this is where the T is under the golf ball, with the golf ball being your humeral head and the T being your humerus. From your thumbs here, you're going to move up exactly 1 inch and you should be right in the middle of the humeral head. It's important to remember that if we choose the humeral head, we need to do 2 things. We need to use our yellow needle if the patient's above 40 kilograms, and we need to remember to place the hand in front of the umbilicus. This keeps the humeral head kind of sticking out so we could find proper placement. It's important that you have to keep the arm there while the IO is in place, because if you let the patient drop their arm, it could damage the site or the needle. Another thing to remember when we're starting the humeral head IO is we're not going in at a 90-degree angle like we did with the tibial tuberosity. You want to go in at more of a 45-degree angle, like starting an IV. What we're going to do is we're going to shoot for the humeral head where it sits on top of the humerus, or what they say the golf ball sits on top of the tee. We're going to push the needle through the skin until it hits the bone. Don't forget, we're looking for that black line to make sure that the needle is long enough. If we're happy with the placement, we're going to pull the trigger only until the hub is flush with the skin. We're going to take this off. Now, when we look at the humeral head, the needle is going to be right in the middle of it. And then you continue separating the hub just like we showed you on the tibial tuberosity. After our IO is placed, we're going to use our stabilizer. We're going to put this on, pull the tab, and this really keeps it on very well. In the IO kit, you're going to have a normal saline lock. This could either be primed with normal saline, or it could be primed with 2% preservative and epinephrine-free lidocaine. If you have a cardiac arrest, you would obviously go with just saline. If you have a semi-conscious patient that could possibly feel pain, you may consider using your 2% preservative and epinephrine-free lidocaine for pain management. The dosage is going to be 40 milligrams for an initial dose. You're going to push it over 120 seconds and let it dwell in the space for 60 seconds. If you need a PRN dose after that, it's going to be exactly half of what you gave the first time. For a pediatric, it's going to be 0.5 mg per kg up to 40 milligrams. If you need a PRN dose for a second dose, it's going to be exactly half of what you gave the first time. So we're just going to show you if we had a saline lock connected to the IO. So you're going to connect your saline lock, making sure it's very tight. What we have to do now is we have to give the patient a 10 cc syringe, and they say that this is supposed to be pushed over 3 seconds. What this is going to do is this is going to break up the bone marrow cavity and push a little of the bone marrow out of the way. Because it's such a dense area, we'll have some room for the fluid to go. So this is connected. You're going to give your 10 cc flush in 1, 2, 3. We're now at the point where our IO is flowing and fluids is going in. What we need to do is we need to assess the patient to make sure that you don't have infiltration. Some signs of infiltration are hardening to the skin, reddening areas, and swelling. It's important to remember that an IO could stay in for a maximum of 24 hours. I'm going to go over the process of removing your IO. You're basically going to do things in reverse. We're going to take our saline lock off. Then we're going to take our stabilizer off, holding on to the hub to make sure that it doesn't come off with your stabilizer. Now you're going to take an empty 10 cc syringe. You're going to put it on the IO in a clockwise motion. Now this isn't very important. We have to put our fingers over half of the hub and half of the empty 10 cc syringe. In one quick motion, you're going to move clockwise and out at the same time, like so. It should come out fairly easy. You're not going to have bleeding like you would from an IV site, so just a dab of a 4x4 and you should be fine.